Imagine this. You're sitting in your living room, a place you've known for years. The layout is familiar, the lighting is warm, but suddenly the edges of the room start to blur. The shadows in the corners seem to detach themselves and move. You try to focus, to shake it off, but your thoughts feel like they're wading through molasses. You hear a voice, maybe just a whisper, but there's no one else there. The panic sets in, not just because of what you're seeing, but because you know, logically, it shouldn't be happening.
Now, if you went to an emergency room with those symptoms, the first assumption might be a psychiatric break. But what if the cause wasn't in your mind at all? What if it was a chemical alarm system in your kidneys shouting that your body is about to shut down?
It's the symptom nobody warns you about. We're talking about hallucinations, confusion, and severe cognitive shifts in adrenal insufficiency today. It's a topic that comes directly from a community article on My Adrenal Life, which highlighted just how isolating this experience can be. I think for a lot of listeners, the idea that a hormone deficiency can make you see things that aren't there is, well, it's unexpected.
It is unexpected, but it shouldn't be. If we look at the medical literature, this connection has been there from the very beginning. When Thomas Addison first described this condition back in 1855 in his monograph on the constitutional and local effects of disease of the suprarenal capsules, he actually listed delirium and attacks of giddiness as key symptoms. He saw it back then. But somewhere along the way, modern medicine got so good at treating the physical side with steroids that we stopped talking about the mental impact of the crisis itself.
That's fascinating. So the guy who named the disease told us over 150 years ago that it messes with your head, and we just kind of forgot.
In a way, yes. We compartmentalized it. We put the fatigue in the endocrine box and the confusion in the psychiatric box. But the brain is an organ, Jake. It requires fuel and a specific chemical environment to run. When you have adrenal insufficiency, you are essentially pulling the plug on the brain's stability systems.
Let's break that down, because I don't want people to think we're saying everyone with Addison's disease or AI is going to start hallucinating. It's rare, right? But when it happens, there's a specific mechanism firing.
Correct. It is uncommon, but it usually signals a medical emergency. There are three main gears turning here. The first is cortisol's relationship with glucose. We know from the National Institute of Diabetes and Digestive and Kidney Diseases, the NIDDK, that cortisol regulates how our body uses carbohydrates, fats, and proteins. But crucially, it helps maintain blood sugar.
And the brain is a sugar hog. It needs glucose.
Exactly. If your cortisol bottoms out, you can slip into hypoglycemia. A starving brain is a confused brain. If you've ever seen a diabetic in severe insulin shock, they can appear drunk, aggressive, or completely disoriented. The same thing happens here. The hallucinations can simply be the brain misfiring because it's running on fumes.
Okay, so that's gear one, lack of fuel. What's the second gear? Because the article mentioned electrolytes, which sounds more like an electrical problem.
That is the salt connection. This is specifically dangerous for people with primary adrenal insufficiency, or Addison's, where they also lack aldosterone. Aldosterone holds onto sodium. Without it, you flush salt out of your body. The Cleveland Clinic outlines this clearly in their guidance on adrenal crisis. When sodium drops dangerously low, we call it hyponatremia.
I've heard of hyponatremia in marathon runners who drink too much water. It can be fatal.
It can be. And biologically, water follows salt. If your blood sodium is low, water rushes into your cells to try and balance things out. That includes brain cells. So quite literally, your brain can swell. It's called cerebral edema. When that pressure builds, neurons can't fire predominantly. You get misfired signals. That's where you get the visual disturbances, the agitation, and yes, hallucinations.
That is a terrifying image. Your brain is literally swelling inside your skull because your kidneys can't hold on to salt. And meanwhile, the person experiencing this probably doesn't feel sick in the way we think of a flu. They just feel weird.
They feel off. And that's the danger. The article you shared touched on something profound, the emotional component, fear, confusion. If you start seeing things, your first instinct isn't usually, I need a hydrocortisone injection. It's often, am I losing my mind? There is a shame spiral that delays treatment.
Which brings us to the third gear you mentioned, the crisis itself, because this doesn't usually happen on a good day, right? This is when the body is under attack.
Right. We call it delirium. If you have an infection, say a UTI or a bad flu, your body demands way more cortisol to manage that stress. If you can't produce it, you hit a deficit. The infection causes inflammation, the fever heats things up, and without cortisol to dampen that fire, the brain enters a state of acute delirium. Research in the Journal of Clinical Endocrinology and Metabolism has shown that this altered mental status is often the first sign of an impending crisis, even before blood pressure crashes.
So if you're a family member watching this happen and your loved one starts acting strangely, maybe they're talking to someone who isn't there or they don't know what year it is, you shouldn't be booking a therapy appointment. You should be checking their emergency kit.
100%. Time is tissue. If this is driven by hypoglycemia or hyponatremia, waiting a few hours to see if it passes could lead to seizures or coma. The altered behavior is the red flag.
I want to pivot to something that feels like a cruel irony in all this. We've established that low cortisol makes you hallucinate, but the treatment for adrenal insufficiency is taking steroids, hydrocortisone, prednisone. And isn't roid rage or steroid psychosis also a real thing? How does a patient navigate that tightrope?
This is the steroid paradox, and it is incredibly difficult to manage. You are right. High doses of glucocorticoids can cause mania, insomnia, and psychosis. There's a distinct difference, though. Steroid psychosis usually happens when levels are consistently too high. We see this often in patients being treated for things like autoimmune flares or severe asthma, where they are on massive doses.
So too much gas in the tank versus an empty tank.
Analogy accepted with a caveat. In an adrenal crisis, the tank is empty. The hallucinations there are often cloudy, accompanied by lethargy, confusion, and physical weakness. Steroid psychosis, on the other hand, is often high energy. It's mania. Rapid speech, feeling invincible, not sleeping for days. But here is where it gets messy. If someone is in crisis and you give them a high-dose rescue injection, they might feel a sudden surge of emotional volatility as they stabilize.
And I imagine for doctors in the ER, this is a nightmare to diagnose if they don't know the patient's history. A guy walks in shouting nonsense. He looks disoriented. If the doctor doesn't check for a medical alert bracelet, that patient could end up in the psychiatric ward.
It happens more often than we'd like to admit. There's a term for it, diagnostic overshadowing. The symptoms are so loud behaviorally that the medical cause gets shadowed. There are case reports in the literature, NCBI has several, of patients admitted for acute psychosis who were actually in Addisonian crisis. They were given antipsychotics, which didn't help, and their physical condition continued to deteriorate until someone finally checked their electrolytes.
That is chilling. It really underscores why that medical alert bracelet isn't just jewelry. It's a voice for you when you literally cannot speak for yourself.
And it brings us back to the caregiver. The article from My Adrenal Life made a beautiful point about the role of the family. The person in the crisis often lacks insight. That's a medical term, meaning they don't realize they are sick. Their brain is telling them the hallucination is real. So the partner, the parent, the roommate, they have to be the external hard drive. They have to recognize, okay, Sarah isn't making sense. Her skin looks pale. She's staring at the wall. This isn't a mood swing. This is a cortisol crash.
What about the aftermath? The article mentioned embarrassment. I can imagine waking up in a hospital bed, being told you were screaming or acting bizarrely, and feeling incredibly exposed.
The psychological hangover is real. Patients often feel like they lost control of their own identity. It's important to validate that. It wasn't a character flaw. It wasn't a breakdown in the emotional sense. It was a physiological event, just like a seizure. You wouldn't be embarrassed about having a seizure, and you shouldn't be embarrassed about metabolic encephalopathy, which is the fancy term for what we're discussing.
Metabolic encephalopathy. That sounds a lot more legitimate than going crazy. Labels matter.
They do, and understanding the mechanism helps remove the fear. If you know that low sodium causes the brain to misfire, then when you start feeling that brain fog or that weird sense of detachment, you can say, okay, I need to updose. I need electrolytes. You have an action plan rather than just sitting in fear.
I want to touch on one other thing mentioned in the research. We talked about sodium and sugar, but are there medications that AI patients take that could contribute to this beyond just the steroids?
Yes, and this requires careful management. Many patients with adrenal insufficiency have comorbidities, other conditions. They might be on thyroid medication or perhaps antidepressants. There are interactions to consider. For example, some painkillers or sedatives can depress the nervous system. If your brain is already struggling with low cortisol, adding a sedative can tip you over the edge into confusion much faster than it would for a healthy person.
So it's a cumulative load. The brain is resilient, but it has a breaking point.
Exactly. Living with AI is about managing that load. You're trying to manually regulate a system that everyone else's body does on autopilot. It's exhausting. And when you get tired or sick, the margin for error disappears.
Let's look at the long-term legacy of this. We talked about Thomas Addison seeing this in 1855. Why do you think it's still considered uncommon or rare in the literature? Is it because we're catching it earlier now, so people don't get to the hallucination stage?
That is a big part of it. In 1855, there was no treatment. Patients deteriorated until they died. So Addison saw the end-stage progression, which included severe delirium. Today, hopefully, patients are diagnosed and treated before they reach that catastrophic level. But, and this is a big but, we still see it in undiagnosed patients. The person who has been losing weight for 6 months, feels weak, gets a stomach bug, and suddenly starts hallucinating. That is often how they get their diagnosis. They come in through the ER, not the endocrinologist office.
That's a powerful reminder. The hallucination might be the bell that saves their life if the doctor listening knows what to look for.
It puts a lot of pressure on emergency medicine providers to look past the psychiatric presentation. The StatPearls database on adrenal crisis emphasizes this triad: hypotension, hypoglycemia, and altered mental status. If you see those three together, you have to think adrenals.
So if we're wrapping this up for someone listening, maybe they have AI or they love someone who does, what is the big takeaway? If they notice these changes in perception, what is step one?
Step one is safety. Do not assume it's psychological. Check the vitals, blood pressure, heart rate. If you have a glucometer, check the blood sugar. If things are off, treat it as a crisis. Administer the emergency injection if you've been trained, or get to the ER immediately. And speak up for the patient. Tell the doctors, this person has adrenal insufficiency. I suspect an adrenal crisis. Use those words.
And for the patient who has been through it, who is sitting there feeling shaken,
Forgive yourself. Your brain was doing the best it could under impossible conditions. It wasn't you, it was the chemistry. You survived it, and now you have the data to hopefully prevent it from happening again.
that's a great place to leave it. It's about biology, not biography. These symptoms are scary, but they are explainable. And more importantly, they are treatable.
Precise and actionable. That's what we want.
If this episode opened your eyes to a side of adrenal insufficiency you hadn't considered, send it to someone who needs to hear it. Awareness is the best safety net we have.